like to call the meeting of the board to order. Will the secretary please call the roll?
Director Bott? Director Bott is absent. Director Curry is absent. Vice Chair Deere?
Dear is here. Good morning.
Thank you. Director Garza?
Present.
Director Harrington?
Present.
Director Kim?
Present.
Director Ryder?
Here.
Director Robinson?
Present.
Director Sorrell is absent. Director Story?
Present.
Director Webster Cross?
Here.
And Chair Taylor.
Present.
You have a quorum.
Thank you. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline, we'll combine the action items into a combined motion. Meetings of the CCH Board and its committees will be held remotely until otherwise noticed due to the determination that a public health emergency exists. The next regular meeting of the board will be held on Friday, March 31st at 9 a.m. The first item on today's agenda is employee recognition, which will be reviewed by Ms. Valerie Amos. Ms. Amos?
Good morning, Chair Taylor and the board. Valerie Amos,
morning.
Chief Human Resources Officer. I'm pleased to share the new hires and promotions. I'd like to share with you that we have welcomed new leadership members, Cynthia Fish, who is the Director of Quality and Regulatory Affairs and Accreditation for Quality Assurance, Philip Hall, who is the Manager of Respiratory Service and Pulmonary Medicine, Eric Hines, who is a Nurse Coordinator 2 in JTDC and Patient Care Services, Nida Prasha, who is the Utilization Management Program Manager of County Care, Lindsay Routledge, who's the Clinical Nurse Leader for Nursing Professional Development. Next slide, please. Karen Williams, who's the Patient Advocacy Manager of Nursing Administration. Emily Zaran, who's the Director of Public Health Emergency Preparedness and Response for Public Health. Ladwina Rudolph, who is the Manager of Complex Care Coordination of Managed Care. Keena Shelton Brown, who is the Manager of Population Health and Performance Improvement for County Care. Next slide. We're also pleased to share promotions. Kathy Dunn, Associate Director of Nursing for Public Health. Dr. Peter Hart, who's the Chair of the Department of Medicine for Medicine Administration. Dr. Tulamat, who's the Chair of the Division of Pulmonary Medicine, and Dr. Priscilla Ware, who's the Chair of the Department of Correctional Health, Medical Director of CIRMAC Correctional Health. Next slide, please. In terms of recognition, I'd also like to share January's Commitment to Excellence Awards. We'd like to thank all of our staff for going above and beyond. So we have Kershit Ali, who's the Respiratory Department, Stroger Hospital. We have Renee Jackson, who's in the Health Information Systems Department. Edwina Solomon, who's also in the Respiratory Department of Stroger Hospital. Melvin Williams, Inpatient 8 West Providence Hospital. Dr. Ashla Winfield, who's in the Emergency Medicine Department of Stroger Hospital. Patient Care Team of the Trauma Unit in Stroger Hospital. And Brian Austin, who's also in Health Information Systems. So to nominate a colleague for a Commitment to Excellence Award, there's an email address below, but we want to thank all of our Excellence Award members. Next slide, please. For Black History Month panel, in celebration of Black History Month, Cook County Board President Tony Preckwinkle joined Cook County Health for a discussion on health equity and health issues that impact the Black community. Thank you to Shannon Andrews, Dr. Fegan, Dr. Mahat, and Dr. McNeil for a successful and insightful event. And this event was taking place on February the 16th. Next slide, please. America's Essential Hospital Fellowship. Congratulations to these leaders who are graduating from the America's Essential Hospitals Fellowship Program this month. Ileana Mora, who's our Chief Administrative Officer for Ambulatory Services. Dr. Whitney Lynn, who's an attending physician for Family and Community Medicine. Christina Urbana, who's our Director of Maternal and Child Health Programs. Next slide, please. Healthcare Digital Marketing Award. Cook County Health's My Shot campaign has won another award. The Healthcare Digital Marketing Awards recognize the COVID campaign with the Silver Award, making it our campaign's 14th award. Congratulations. And next slide, please. Healthcare Digital Marketing Award continues. So last year, County Care's Choice campaign, County Care is There, has won a gold award from the Healthcare Digital Marketing Awards for our total digital marketing program. This is the campaign's 5th award. Congratulations again. And next slide, please. End of public health emergencies.
I think that's the
We
end of it.
will share that with, thank you, Mr. Rocha. Please congratulate all of our new hires, our promotions, and all of our accomplishments and achievements. Thank you so much.
Thank you very much. We'd like to our hats off to all the achievements that we've had, and also great to see, welcome our new colleagues. Great to see the progress on these critical hires. The next item is public testimony. Madam Secretary, do we have any speakers who have registered to provide virtual oral testimony?
We did not receive any registrations to provide oral testimony, but we did receive one written testimony from Genevieve Lewis Piotrowski, which will be emailed to you in a few minutes, posted to the website, and included in the meeting minutes.
Thank you, thank you. As a reminder, written testimony will not be read into the record, but will be included in the official record of this meeting and posted to the website, as the Secretary indicated. If we had any, following receiving any oral testimony, which we do not have any, the Secretary could read the list of names of those who submitted written testimony into the record, which she has done. Thank you. Next on the agenda are the board and committee reports. The minutes of the January 27th board meeting are being presented for your approval, and will take approval will take place in the combined motion later in the meeting. Are there any corrections or revisions to be made to the minutes that you received previously? Hearing none. Next, Director Garza will now review the HR meeting minutes. Director Garza.
Thank you, Mr. Chair. Good morning, everyone. The Human Resources Committee met on Thursday, February 16th at 12 p.m. The next regular meeting of the Human Resources Committee will be held on Thursday, May 19th at 12 p.m. We're not planning to have the staff re-review the report this morning from that meeting. If any additional questions are raised regarding the presentation or metrics contained within the minutes, of course, staff will be present and ready to address those questions. The report from the Chief of Human Resources Officer is included information on the following subjects: the FY 2023 Impact Summary and HR Activity Report hiring, the FY 2023 Impact Summary and HR Activity Report turnover and separations, HR optimization, vendor overview, vendor summary, slalom, HR optimization and digitization, vendor summary, Deloitte, workforce development, vendor summary Deloitte, vendor summary cross country, outreach and marketing, vendor summary Brazen, and FY 2023 strategy. During the discussion of the data on turnovers, which was slide 6 specifically, Director Robinson noted that the data presented was post-pandemic. He was asking what the data looks like pre-pandemic, and Ms. Amos responded that she can share that information. With respect to action item, the committee considered one CBA, which included an economic package to include wage increases and healthcare between the County of Cook and the Cook County Pharmacy Association, Chicago Joint Board Retail Wholesale and Department Store Union, RWDSU, Local 200, representing pharmacists, postgraduate pharmacist residents, and pharmacy technicians. The CBA was fully reviewed by the committee in a closed meeting and was recommended for approval by the committee. It will not be re-reviewed today, but if any directors have questions, we'll hold off on approving the minutes until the questions are addressed in closed session later this morning. Otherwise, if there are no questions, the minutes are being presented for approval to be included in the combined motion that will be made a little later in the meeting. Upon approval of the minutes, upon approval of the minutes, that confers board approval of the CBA contained within those minutes. Are there any questions that need to be addressed in closed session? Okay, hearing none, we will hold off for the combined motion or for after closed session if there are any questions on the CBA, which doesn't appear that there are any questions. Mr. Chairman, that concludes my report.
Thank you very much. Next, Director Harrington and Aaron Galena will now review the Managed Care Committee metrics. That committee did not meet this month, so the metrics are being presented directly to the board.
Thank you, Chair, and good morning, directors. We'll start today with our membership numbers on the next slide. So through February, we're at 450,000 members, a little over 40,000 in terms of members that are impaneled at our Cook County Health clinics. The next slide shows our market share data, where we continue to be in the high 32% range, continuing to see that incrementally increase. The rest of the market has stayed relatively steady since the last view of this data that you had. I'll also note this data is through December of 2022. The next slide shows the increase that we've seen in our enrollment versus the overall Cook County Medicaid managed care market. We have just slightly outpaced the growth in the overall Medicaid managed care market over the past 12 months. The next slide shows our budget versus our actual membership year to date through February. The red bars are our actuals, the blue is our budget. As you know, we planned for redetermination to begin towards the beginning of this year, which is why you see the declining membership and the budget numbers. We now know that redetermination will begin in April, and we expect to see some of the initial members losing coverage starting in July. And so we expect that we'll for most of this year exceed our budget projections based on the timing of the redeterminations. The next slide shows our operations metrics. As mentioned previously, we've seen some challenges in call center performance and are making some adjustments there, and we'll be talking more about that in our next managed care committee as well. The next slide shows our inpatient admissions per 1,000. The red bars are the prior period. The blue bars are the dark blue bars are actuals. The light blue is projected utilization. And you can see that we've continued to see a relatively positive trend in terms of inpatient admissions overall in our population. The next slide shows our COVID vaccination rates. We had also added some benchmarks here based on CDC data. This is also a topic that we'll be sharing some additional information on in our next managed care committee meeting. We had received some follow-up requests from board members around sharing some heat map data, which we'll be presenting in the April managed care committee. And then the next slide shows our claims payment turnaround times. you can see we had the uptick as we talked about before in the end of the fiscal year. We're starting to really see that come back down, and even in the past couple of weeks, this has come down even further, and is getting back pretty close to where our expectations would be around the 30-day mark. And then the next slide shows that same information, but presented by the aging categories. And you can see that really in the 30 to 60-day range is where we saw the biggest increase in some of the timing of those payments. And again, that's come down pretty significantly over the past 30 days, and we're back around that 50-day mark as we would expect to be. And with that, I'm happy to answer any questions.
Do you have any questions? Hearing none. Next, Director Kim will now review the Quality and Patient Safety Committee meeting minutes.
Thank you. Good morning. So the Quality and Patient Safety Committee met on February 16th. I'm not planning on re-reviewing any metrics and presentations from the meeting, but if there are any additional questions, we can present and are ready to address them. Our next meeting is going to be on Thursday, March 23rd at 10:30. Regarding public testimony, we had a very compelling public testimony, and following the presentation from a patient regarding her family member, the committee requested that the administration provide a follow-up report on this particular case involving the patient experience. And Lynn Dang, the Chief Experience Officer, is going to reach out to Ms. Cole and provide a follow-up report. Craig Williams, who's our Interim Chief Administrative Officer and Operations and Development, will provide a follow-up report on the portion of the comments involving the environmental services. The committee received the following reports, which are included in the minutes. The HRO dashboard, the committee reviewed metrics on the following subjects: the 30-day readmission rate at Stroger, the case mix index, clinical documentation, medical and surgical MS-DRG at Stroger Hospital, the top box score, patient experience, and recommend the hospital Stroger and recommendations from the hospital Stroger Hospital, the HEDIS hemoglobin A1C greater than 9%. We also received regulatory and accreditation updates, which are included in the minutes. There was a request from Director Story who wanted information on the most recent mock survey. And Dr. Makaitis responded this information will be provided within the next 2 weeks. We also received updates from HRO Clinical Documentation Working Group, which is included in the minutes. We received updates on CCH specialty care in terms of access, wait time, and referrals. And we received an update on the recent joint conference committee meeting, again, all included in the minutes. We received EMS and MEC reports. The Stroger Hospital and Providence Hospital medical staff action items were presented for the committee's consideration. Sorry. The committee approved the following action items, which are included in the minutes. We approved the Stroger and Providence Hospital medical staff appointments, reappointments, and changes. We did go into closed session, but we're not expecting to re-review that information. So the minutes are being presented for the board's consideration as part of today's combined motion to be made later in the meeting. Thank you.
Thank you, Director Kim. Next, Director Ryder will review the Finance Committee meeting minutes.
On Thursday, February 16th at 9 a.m. The next meeting of the committee will be held on Thursday, March 23rd at 9 a.m. As the other directors have said about their committees, we're not planning to have staff re-review reports and contracts from the meeting. But while you are reviewing the minutes, Deb will have a slide reflected with a list of contractual requests greater than $1 million. If any additional questions are raised, Charles, Pam, and staff will be present and ready to address. So take a look at those. We conditionally approved 18 contracts and procurement items. Numbers 4, 9, 10, 11, and 18 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee, whose fiscal impacts again are greater than $1 million, which are highlighted for your information. There was a request, request number 12, extend and increase the contract with Hall, Render, Killian Health, Heath, and Lyman PC for legal work, internal review of research and clinical trial work. There was a request for a presentation to be made to the board regarding their work in the Life Sciences Department. The presentation is anticipated once they have helped us work out exactly what the Life Sciences Department looks like and what the jobs in it should be included. So we're looking forward to that. We received and filed grant award related items. The committee received the following reports, which are also included in the minutes. The fourth quarter fiscal year 2022 report of contracts executed under the authority of the CEO, a report of 2 emergency purchases, timeline in the RFP process and transition for GPO services, and report of the December 2023 financials. The action items, reports, and presentations from the committee meeting are included in the meeting minutes. If there are no other questions on the information, the minutes are being presented for the board's consideration as part of the combined motion to be made later in the meeting. And I should say that the report on the financials actually, I believe, through the December 2023 financial, or 2022, not 2023.
Right.
So, Mr. Chairman, if there are no questions, that is my report.
Thank you. I don't see any hands raised, so no questions. Appreciate it. We do not have any contracts being. Thank you. We do not have any contracts being presented directly to the board for consideration. So if there are no other questions on the minutes and the action items being presented for consideration, we can move to the combined motion. Before we do so, I'd like to recognize that Dr. J. Bob is in attendance. Madam Secretary. I'd like to entertain the following combined motion to approve the following. Item 4A, January 27th board meeting minutes. Item 4B, February 16th minutes of the Human Resources Committee meeting, which include the proposed CBA with RWDSU Local 200, representing pharmacists, postgraduate pharmacists, residents, and pharmacy technicians. Item 4D, the February 16th minutes of the Quality and Patient Safety Committee meeting, which include the Stroger and Provident Hospital medical staff appointments, reappointments, and changes. And item 4E, February 16th minutes of the Finance Committee meeting, which include contracts and procurement items and grant award related items. Do I have a motion?
So moved, Director Harrington.
Second, Director Deere.
Thank you. The combined motion has been made and seconded. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Bott?
All right.
Director Curry is absent. Vice Chair Deere?
Deere is aye.
Director Garza? Director Garza? I'll circle back to him. Director Harrington?
Aye.
Director Kim?
Aye.
Director Ryder?
Aye.
Director Robinson?
Aye.
Director Sorrell is absent. Director Story?
Aye.
Director Webster Cross?
Aye.
Chair Taylor?
Aye.
And circling back, Director Garza, are you with us? He may have stepped away. So, Chair, you have 9 yeas and 3 absent.
The ayes have it. Thank you. The ayes have it. The motion carries. The next item is a quarterly report from the Cook County Department of Public Health. Dr. Hasbrook will provide an introduction to the presentation, and Felipe Tindek Martinez. Well, I'm sorry for your name. Martinez will review the slides. Dr. Hasbrook.
Great, thank you, Chair Taylor, and good morning to the director. So yes,
Morning.
we have our quarterly report and we want to make sure we're highlighting different features of what we're doing here. So today we're going to highlight what's going on in our Healthy Work Initiative. As you all know, COVID has revealed a number of challenges across various different communities. Essential workers and their vulnerability has been one of those. And so this program is really focused on improving worker safety for some of those essential and vulnerable workers. So I'm going to turn it over to Felipe, who leads our work in this. He's going to walk us through the presentation and be available for questions. And I see is there a question already with Director Harrington before we start, or is that from before?
It's an accident.
Oh, okay. No problem. All right, turning it over to Felipe. Felipe, it's all yours.
Great. Good morning, everyone. Glad to be here. So I'll first start off with just saying that this has been a few years in the making, with organizations on the ground that are addressing issues of labor and work and how that connects to social determinants of health, health equity, and the mitigation and elimination of negative health outcomes. And in addition, we're adding the promotion of positive health outcomes by working with community worker organizations to focus on systems changes. So this specific slide wanted to orient you on the connection between health and work. In particular, health inequities, they can be reduced, we find, by promoting safe, healthy, and secure work. Several factors negatively affect workers' health and their ability to sustain themselves, which include inadequacies in labor laws, structural racism, immigration policies, ageism, some examples. And what we found, as Dr. Hasbrook has highlighted, is that during the pandemic, a lot of these conditions have been exacerbated and emphasized. So what we've seen, next slide, please, is that what we would aim for is in the blue box, and I won't read that for you, but what I'll say what we've seen over the past 4 decades is increases in health disparities in employment and health. We've witnessed decreases in high quality full-time employment with adequate wages and benefits, and we've observed increases in precarious working conditions and in income and wealth inequities. Next slide. So precarious work, before I get into this, precarious work itself is there's no standardized definition, but it can be broadly defined as uncertain, unstable, and insecure work in which workers, as opposed to business or government, bear the risks associated with work and receive limited social benefits and statutory protections. Some examples are workers such as day laborers or temporary workers. We see a lot of immigrants, people of color, concentrated in precarious work. And so our vision for this initiative is to end precarity and establish an economic culture that values and prioritizes worker health across suburban Cook. Our overall goals are not only to coordinate and expand access to services for low-wage workers, but also to improve the regulatory environment for increased health and safety on the job. This should result in decreased violations of worker health rights and safety standards, and increased adaptation or adoption of healthy work standards among communities, businesses, and employers. Next slide, please. So this shows our approach in general. So what we have focused on is augmenting data related to precarious work and information to drive our strategy and program planning. We've been focusing on increasing awareness of work itself as a social determinant of health, focusing on supporting outreach and education and policy development for improving workers' rights and health and safety, which we've built on from previous years of work with county's leadership on minimum wage and earned sick time leave. In addition, we're focusing on building worker and community assets and power to recognize and address workplace violations. And finally, overall, to ensure a collaborative multi-level approach for enforcement. Next slide. So throughout the inception and our focus, we have assured that there's alignment across international, national, local, and regional planning and strategic thinking. So this slide just highlights the connections between the World Health Organization to the American Public Health Association, planning to federal and regional safety from the CDC within the NIOSH system, which is part of the CDC, which is focused on occupational health and safety. And in particular, we've added to the Cook County roadmap, and every several years we work on a WE plan, and we have aligned all these focuses to build this program. Next, please. So I wanted to highlight a few key partnerships. In particular, the Raise the Floor Alliance is our next state of engagement involving bidirectional learning, where we can bring in their expertise and application of human rights and working conditions interventions throughout the region. And as an umbrella organization, they have been supporting worker advocacy groups to responding to the increasing situation of precarious work, and in particular, the response needed to respond to COVID-19 and the ongoing pandemic. Jobs with Justice is another highlight. They are providing technical assistance and expertise to worker-centered organizations to help with our integration of co-enforcement of public health laws. In particular, within our own systems, we're developing and advancing relationships with the Commission on Human Rights and connecting to the ordinances that have come into play with earned sick time and minimum wage, and looking where we can add on to that in the future. Next slide, please. I won't go comprehensively into these, but this is just to give you a snapshot that we have 6 program areas, and we're going to highlight a few in the next slides of just what we have underway. Some are under planning and others are in implementation stages. Next slide. So in particular, this is the Worker Protection Program. It was implemented during the height of COVID-19 pandemic. These are some of the statistics of results we've found. This is funded through our state contract tracing grant. We gave sub-grants to Raise the Floor and other worker advocacy organizations to conduct worker safety and rights trainings, and to distribute PPE and other needed resources to precarious workers. Next slide, please. This is our Community Action for Worker Safety program that is being implemented by Warehouse Workers for Justice in the southeast side of the county. In particular, we're providing training, deploying activists in the community, and building a permanent coalition structure to support ongoing worker outreach, workplace oversight, support workplace safety committees and labor organizing, and in particular adding to our co-enforcement approach, where labor standards enforcement agencies can engage in sustained partnerships with worker centers, unions, legal advocacy organizations, and other community-based organizations embedded in low-wage worker communities and high violation sectors. Next slide, please. Looking ahead with equitable enforcement, we've added this component to our co-enforcement model. Equitable enforcement is a process of ensuring that compliance with law and policy that considers and minimizes harms to people affected by health inequities. This could be such as our CCDPH inspection staff would communicate with OSHA or the Commission of Human Rights for labor violations observed during environmental inspections. So we're working on that kind of bi-directional collaboration with other agencies. And worker groups and community partners can function as a watchdog to report workplace violations and work with CCDPH on enforcement measures. So far we have funding through ARPA through 2026, and we're looking to expand this beyond that point. Next slide, please. So further on, looking ahead, we're continuing expanding the work of the original Worker Protection Program, which means we're training workers and employers on workers' rights. We're training on hazard recognition, assuring confidential reporting of violations, and building out worker leadership and across the county to address and alleviate these issues. Next slide. Another highlight here is our relationship with the UIC School of Public Health, Center for Healthy Work. We're conducting an environmental scan to understand the current state of precarious work in suburban Cook County and the best practices and interventions for improvement in the health and safety low-wage precarious workers space. We've adapted their center's curriculum to support communities, intersectional teams, and collaboratives to work on the adaptation and adoption and implementation of strategies that promote healthy work. So we're looking to embed that in our programming. The Healthy Work Agenda and the Healthy Working Collaborative will provide a structure to address identified gaps. If they're aligned well, the noted results that we're looking for is increase in knowledge and understanding, increases in cross-sectoral partnership to decrease fragmentation and service delivery, focusing on increased expansion of healthy work approaches, and finally increases in community and worker-led engagement and policies, plans, and protocols. Next slide, please. And so what we're looking forward to here in the coming years, convening various partners to launch a partnership in the spring. The purpose is to promote communication, coordination, and we're expected to guide that conversation with environmental scan that's going to bring the most up-to-date data in the region. So thank you all. I see a hand is raised, which is perfect because I have the last slide is thank you all, and any questions are welcome. And I'll keep my jokes to myself. I tend to joke a lot, so.
That's fine.
It looks like Director Harrington
Goes a
first.
long way.
Director Harrington?
Yeah, you talked about precarious workers, and I'm wondering what that really means.
Yes, so I gave a definition, but broadly speaking, the way it's observed often in the field is workers that don't have consistent labor titles, labor rights, inconsistent schedules, differences in pay, consistent changing operations. Gig workers oftentimes are classified as precarious work, but usually it's defined as unpredictable working schedules and pay and or legal protections, because they might operate, for example, like temp agency workers don't actually have all the protections that fall under the Department of Labor. Oftentimes they're kind of in these gray areas, and it's difficult to find out who is accountable, which employer is actually accountable for their working conditions. It makes it difficult to create changes that alleviate hazards and safety and violations. So I don't know if that helps explain a little bit further, but yeah.
Yeah, it does have a follow-up question.
Mhm.
So I know you have a website. How do they find you? How do you do outreach? I'm trying to figure out how they could connect it to the program.
That is something that's in development. Currently, it's through our community partnerships. So it's through the organizations that we've partnered through, and that's the primary way. We're working on other methods to improve that. But currently it's through our partnerships and relationships with organizations that are on the ground.
And how many are engaged in our project? You may have said it, but I may have missed it.
Yeah, we have a couple critical partners.
No, not
I mean,
partners, but
oh,
precarious workers. How many have we touched? How many have we reached?
well, on one of the previous slides, we had at least through the first year and a half or so, we've reached about 100,000 through those partnerships, those organizations. And that looks like at least the last year, a lot of that's COVID related, COVID response to health and safety. So that can be passing out protective equipment. It can be in conversations of violations and rights and understanding their rights.
So, and this is my last question.
Yeah.
So if someone's rights are violated, do we take any action, or we just advise them of opportunities to reach out to an organization or someone that can help them?
Yeah, a lot of it is through organization to understand where to properly to go to submit that violation. I'll just say this is a larger issue at hand. It's been a challenge across the board because there's a lot of the capacities at the state, regional, and federal levels. Just they do not have the ability to actually go into to see every violation. So some of these approaches we're utilizing now is to find the best methods to get those in. But I would say, yeah, that's an ongoing issue of if there is a violation, how does it get alleviated? And I think that's why we have 40 years plus of trend data that just show diminishing conditions.
Thank you.
Yep, you're welcome.
Did I see another hand earlier?
I
Yeah,
think it's Director Ryder.
yes. Thank you, Mr. Chairman. I just, to just chase a little bit on that last comment that Director Harrington made. As an organization that helps to support the creation and passage of some of these statutes and ordinances, the one thing that we always make sure that we do is, as an organization, is make sure that there's funding attached, because 15, 20 years ago we were passing a lot of laws with no funding attached to it, so the agencies weren't didn't have the capacity to actually enforce. And that's one of the things that we've done the last few years, is helping to create the Office of Labor Standards for the city, making sure that the Illinois Department of Labor is funded. But I really just wanted to comment on how great I think it is, not only our recognition of worker issues as being a co-determinant of health, but the depth to which the Cook County Department of Public Health is actually going into work with different organizations in the space. Obviously, a lot of these organizations, I've either been an active participant with them in the past or a coalition partner. Whatever I can do to help support this work, not only here on the board, but also as a in my day job, always feel free to reach out, because I just think it's incredible that we are going into the depth that we are, and UIC is such an important partner. I sit on an advisory committee for the School of Public Health on these types of issues. So this is one of the things that really really impresses me with the work we do, that we are so holistic as the broader organization, the public health, and obviously the hospital, and making sure that we're dealing with health as a whole person. So that's all I have. I couldn't let this one go by without saying how happy I am. Thanks.
Thank you very much, Director Ryder. Debbie, do we have any other hands raised? Any questions?
I do not believe so.
Actually, I do. I have one question. Felipe, can you please pronounce your name for me, for my benefit? So for the future, I will pronounce
I'll
it
look you in
correctly.
the eye too, as best as I can.
Thank you. Thank you.
I didn't want you all to see my face changing as I'm trying to present. Felipe Tendic Matasan. And if you want it in my Spanish style, is Felipe Tendic Matasanth. But that we can do that another day. Appreciate
it. Thank you.
Yes, thank you all so much. Have a wonderful day.
You as well.
Thank you, Felipe.
Dr. Hasbrook, do we have any additional?
No, Chair Taylor, and I was just thanking Felipe for his excellent presentation and filling the questions, and thank you all for your support. Nothing else for me.
As well. Nice. Well done. Well done. The next is the CEO report, Mr. Rocha.
Yes, absolutely. So I wanted to share today the end of public health emergencies. Next slide. As you have probably heard in the media and other information, the Medicaid redetermination process will commence starting in May. Federal and state COVID-19 public health emergencies will be ending. Medicaid redetermination begins on April 1st. It has been paused for 3 years under the federal and state public health emergency. What this means is that all Medicaid members will be up for redetermination on a rolling basis for the next 12 months. An estimated 384,000 to 700,000 Medicaid members are expected to lose coverage during ineligibility due to lack of completing redetermination paperwork. Next slide. So what can we do? What we can do is to make sure that everyone's informed, that they are able to get the information to the Illinois Medicaid office so that they can make sure that their information, their address, and all the particulars are submitted to avoid any unnecessary redetermination of impact. We can educate Medicaid members that redetermination is starting. We can encourage them to update their mailing address with the Illinois Department of Healthcare and Family Services by calling 877-805-5312 or visiting the HFS website to make sure that their information is updated. These are available on the phone call. They're available from Monday through Friday from 7:45 to 4:30 p.m. Of course, online is available 24/7. We encourage everyone to please take this act to make sure that your information is updated to ensure that there is no disruption in your care services if you remain eligible for Medicaid services. Next slide. Next, I would like to recognize Angela O'Banion and Eliana Mora for OneSource Enterprise Update. This is a very exciting project that we have been working on across our Cook County Health System that will bring some new patient access and opportunities for our organization. And it's a program that we are very pleased to bring to an update to the board. So with no further ado, happy to recognize Ms. Angela O'Banion, Eliana Mora.
Good morning. This is Angela O'Banion, Chief Information Officer. Ileana Mora of our Chief Ambulatory Services Officer, and I will spend a few minutes this morning introducing you to a very exciting initiative that we have, OneSource Enterprise. Several months ago, Mr. Rocha asked Ileana and I to partner together and with our partners lead CCH to completely transform our patient access and our contact center operations. Since that time, we've had hundreds of focus groups, interviews, design sessions, strategy meetings with our strategy leadership to meet this objective of improving patient access and experience. Next slide, please. In summary, OneSource Enterprise is an on-demand personal and patient engagement platform that ensures that when a patient calls a single number at the hospital, at the Cook County Health, for their non-urgent care needs, those needs are immediately met, their non-emergency needs. Whether those needs are to schedule an appointment or immediately speak with a healthcare provider, we are using primarily our existing technologies and making them more innovative in order to provide a number of services, including telehealth technologies, as illustrated on this slide. Next slide, please. As you can see on this journey chart, the multi-year, multi-quarter aim is to eventually connect multiple services and providers for our patients. On the left, you can see the types of services that we are offering. And to the right in the body, you see not only the timeline, but the rollout schedule for our implementation, which actually begins with virtual care, which we are categorizing for the purposes of this slide as urgent care and nurse triage. And with that, Ileana will speak briefly about our current urgent and nurse triage operations, which are part of this OneSource Enterprise and being leveraged by this OneSource Enterprise that will launch this spring. Ileana?
Good morning. On to the next slide. All right. So we want to introduce you to the first phase of this work, which includes virtual care. As Angela said, virtual care is going to consist of a virtual nurse triage and as well as virtual medical appointments and then connected to on-site urgent care. So the intent is to ensure that we increase our accessibility to primary care services in the first phase to all of our patients and anyone interested in getting access from Cook County Health. The way it will work is that we will have one digital front door and we will have that first group of clinical providers being the nurse triage group. And they will serve as really a triage resource, meaning patient calls in, their baby has had a high fever, and the nurse can likely manage that high fever per se, based on, of course, looking at the risk, but can potentially handle and guide that mother on the how to handle a high-risk baby fever. However, if for any reason the RN is not able, there are other symptoms that make it a more complicated case, then a part of that virtual team are physicians or providers, mid-level providers, advanced practice providers as well, where that virtual RN can then pass that one patient over to virtually, immediately, over to a provider who can further assess the patient in the particular case virtually. If that provider is able to care for that one single visit in that virtually, then we're done with that visit and we can refer that patient to any follow-up care if necessary in the weeks or ahead. However, if for any reason provider deems that that patient really needs to be seen and immediately, then we're building in the urgent care, on-site urgent care as part of this model of care, which I'll talk about next. And that provider will be able to immediately refer that patient into one of our urgent care settings for that patient to be seen on site instead of the emergency room. So the intent of the virtual care center really is focused on ensuring, one, immediate access to patients, two, whether that's the nurse clinical triage team or the providers, and also will be connected to our on-site urgent cares. Additionally, the intent is not just for patients calling in for immediate needs, but there are also a variety of needs that patients have, not just for a medical appointment, but they're calling in for a prescription, they're calling in for additional questions regarding a visit that they just had with one of their providers. They're calling in for all sorts of reasons that can also be handled by that virtual nurse team. And the beauty of that is that it will be answered live. So as we all know, sometimes we call our provider or physician offices, we leave a message and we wait for someone to call us back. The intent of this is also to reduce that and to eventually move to a model where somebody is actually answering the phone and can take care of your need live. So of course, this is phases of work which will work over time and phase all of these pieces in. And though this is the bigger vision. One last point on this before I move on, and that is that we have already started piloting a telephone triage nurse call center over the last year in our own patient contact center. We have been able to roll in a couple of our primary care centers so that, again, that patient is taken care of live when they have a question for their care team. And that will be combined with this program as well. So it'll be part of it, but this will allow us to really dramatically move faster in the direction of being able to offer this to all of our patients. If we move over to the next slide, we'll share with you the first phase of the urgent care scope of service. We plan to launch it first at Belmont Cragen. We worked with County Care to look at the data on utilizations of ER. We also took a look at where we had immediate availability of space. Again, that would be easy access in the community. The key to urgent care was to not just create extensions of our own emergency room embedded in our community health centers, and also open the hours that our sites, community sites themselves are not necessarily open. And so we're starting with a very, very first phase, which is the hours that you see there, as well as the scope of services that you see listed. Our goal is, of course, to move to a full work week of hours, more than 40 hours a week, of course, because we have to cover Saturdays and Sundays and evenings, and then expand to the other regions of our Cook County suburban area, again, to complement the 2 hospitals located in the city. So this is the first phase of the urgent care, which again is the physical location portion that will be part of that virtual care piece that is part of the virtual MD and the virtual telephone triage. Thank you.
Thank you so much, Ileana. I'll spend just a few more minutes talking about patient experience. One of the things that we hope that you remember, keywords: on demand, empowered existing technologies fueled by artificial intelligence. One of the reasons we were able to move so quickly is because Ileana's team and our technology teams and across the organization have already made steps towards transforming our patient access. So we're taking some of the existing processes, technologies, and enabling them more. For example, in our patient experience, Ileana talked about patients. Next slide, please. Ileana spoke about patients being able to self-schedule, and next slide, please. Ileana talked about patients being able to get a variety of services. Included in those services on the journey map were being able to schedule. Radiology will be the first online scheduling that we will offer, thanks to the leadership of that team. And there are so many teams and leaders who are enabling this. I won't list them all here, but we will have an opportunity to talk to you a little bit more about patient experience enhancements like self-scheduling on a mobile app, or through our internet services, or through our Cook County portal that we have. So patients, and they do not have to be existing patients, which is one of the reasons why the website is important. It's important to offer these services agnostic to your EMR, because you will likely be getting patients who are not current patients into your system. And you want to have a technology way for us to be able to deliver services to them. And on the next slide, we are going to empower the agent. As Ileana spoke, there is an existing patient contact center. The new patient contact center, again, fueled by a number of technologies, will allow an agent to have a 360 view of a patient's services, including services external to Cook County Health. And this will allow us to achieve all of the objectives that our public health team have been talking about, that Mr. Rocha have been talking about, related to our Change Institute and providing holistic care to patients regardless of how they come to us. We look forward to having more discussions with you in detail about this, and the next slide is the end, but we look forward to having more discussions with you about all of the enabling technologies that we'll be using. Of the over 50 technologies used to empower these services, more than 45 are existing technologies. So we'll be talking to you about more processes, more patient experience, more access to them, and how we will use our health cloud and our customer relationship technologies to bring this all together for a transformational patient access and experience with on-demand care. Thank you.
I see a hand raised. Yeah.
Director Harrington.
Director Story raised his hand prior to mine.
All right, I can see one. Yep, Director Story.
Thank you, Chair. And I thank Ileana and Angela for the presentation. Very impressive, very impressive. Couple of questions. Ileana, I'm just really excited about the ability to use, technology, obviously, to expand the call center. One question relative to the expansion of the call center, and I know that you referenced the physical location and talking about phase 1, Belmont Creek. Can you just share with us relative to the plans to go forward with county care's involvement? Where's that intersection and just in general, when will that timeline sort of take place? If you can just give us a little hint about additional work that will be forthcoming.
Additional work related to how we will work with county care.
Yes.
So we've been working with them the entire time, actually, on the planning of it. From the very initial planning, when I listed the scope of services, they were part of, or the data and so forth that they have on claim utilization and our own claim utilization in terms of what the scope that we wanted to include, that were cases that should not have been going to the ER. So the scope of service they were part of. They were part of, pardon?
No, I was just going to add a little bit to that, Eliana, just to look at it. So, since we have, and we wear many hats at the Cook County Health Organization, on the clinic side, and this is for all our patients, we want to make sure that everyone's treated equally. As Leanna said, we looked at all our payers, all our data, to make sure that we were properly ensuring where we have opportunity to improve. So with all the plans, we have different measures and metrics for performance. This module will be working very closely with all of our patients and all of our access points to make sure that we are giving everyone equal opportunity. We're going to be working and reaching out to county care and all the plans about how we can coordinate better with the patients to avoid readmissions, to avoid all of the value-based contract plans that are requiring, especially on those that we all work together to reduce readmissions, to reduce avoidable delays in care. And so we look forward to contracting them out. So we're first building the platform that will allow people to have access to our clinics universally, and then we're going to be reaching out to every single plan. On the county care side, now we're in the other hat, they also are developing some applications that allow not only for direct clinical care access, but they have some exciting things that we're going to be bringing to the board to present that actually is going to be providing wraparound services for the patients, like food and nutrition delivery, for expediency, for help and housing and other assistance, and very innovative programs to have immediate care programs available to them. So we're approaching it from both sides of the inn. Each organization taking their services online, and then we're going to coordinate together to make sure that we create a seamless experience for the patients. But we want to make sure that we're creating on this side for this application that it's uniformly available to all our patients and all our payers, but we will be coordinating with all of our payers individually on how they can have their members access this platform and what we can do to drive value-based care together.
So this will be a significant marketing campaign, just with, like I said, on both sides, and I appreciate that. Thank you, Eliana, and thank you for that expanded explanation. This is going to be exciting. I mean, this is what I sense that we're all working towards in terms of population health, change institutes, working to close these gaps, and using technology to advance this is what. Not being a techie, but I'm excited that AI has a role in driving this. So thank you all for a wonderful presentation.
Director Harris?
I have two questions. One of the goals of this is to enhance the patient experience. And I'm wondering what our baseline is and what metrics we have in place to actually establish that we've improved patient experience.
Yeah, so we have two measures in Prescani that we'll be monitoring at a minimum. One is care team, how easy it was to contact my care team. The other is how easy it was to schedule an appointment. So there's an access measure, and then also a message around, being able to talk to your care team once you've left. So those are definitely two. The other is outside of patient access, but also related to patient access, is just taking a look at utilization and how easily we're able to point and or take care of that when that patient call comes in immediately versus having to refer, and then once we refer, being able to appoint. So those are all the metrics we'll be looking.
Okay, and we already have a baseline.
Yes.
So say this is where we were and this is where we are now. Okay, thank you.
Correct.
The other question is, how long is phase one?
Phase one is, we do have plans for the other phases. You know, we're hoping that phase one is in the 3 to 6 month range.
Okay, and so you would be able to report back after phase one is ended, and let us know when the other phases will start and have some idea of how well phase one went.
Correct.
Thank you.
And just to add a little bit to that, the metrics that we'll also be looking at is access and availability, how quickly patients are able to come, ED avoidance. And so if someone doesn't need to come into the ED, we can use a virtual platform to get the scripts refills, to get medications, to be able to get assurance. Sometimes people come into the ED at night because they need assurance. Part of being able to provide providers, nurse hotlines, triage lines, scheduling is to hopefully reduce any time that they don't need to come in and to ensure that the right people are coming in. So all the metrics around those utilization, avoidable ED use, possibly preventable conditions, possibly preventable admissions, possibly preventable visits, we're all going to be looking at those as well. And so there will be an entire metric and panel of quality indicators that will actually look at care processes. The baseline is what we have right now. Then we're going to say program went live, what's happening. And then we're going to also have utilization measures and metrics. And then we're going to have time to access metrics. So you're going to have 3 panels that will have a series of metrics. And we're happy to come back and share with the board how it's driving value and care, improving access, and avoiding any kind of unnecessary utilization.
Thank you very much.
I have a basic question. We've all heard about nursing shortages and we've been challenged on nursing shortages. Do we actually have nursing staff to support this effort?
This actually is an exciting opportunity. What we're getting a lot of questions from is our team on how they could either have a day or 2 to be able to do things online through telehealth, through other opportunities. So being able to create these types of programs will allow us to also offer and be more competitive in the market by saying that there might be a day or 2 or shifts that could be taken through this type of processes and programs. So we're going to have to, work on our staff internally and bring in some resources, but long term, we think this is one of the things that will make us more competitive as an employer because you'll be able to drive that. And then more importantly, once people know both ends of the technology, when they're on the hospital side or the clinic side, they're going to be able to refer patients and tell them how easy of access it is, and they're going to see familiar faces. So when we launch, we might have to borrow some interim resources, but long term, our goal is to make this be a selling point of our employment and streamline our staff and give some people some opportunities to work in different modalities while still remaining in acute care in the clinic, in the hospital, but also having some telehealth availability as well.
All right. So to be clear, to launch phase 1, we're going to have to bring in interim staff, the nursing to support this.
Some, yes. We are going to try to do it internally, and we will also need to do some interim staffing.
Okay. So we'll probably need to look at that when you come in to make sure.
Yes. Correct.
Well, probably we'll need to look at that. Right.
Yes.
All right. Any other questions, directors? Thank you very much.
Mr. Chair,
yes.
If we could digress back, I was trying to find out when to ask the question. This is Director Deere, and I guess this is more appropriate for Israel. We can digress back to redeterminations. You gave out a cadre of modalities that we could reach out to our consumers about redeterminations and making sure their house is in order so that they aren't in a situation where they're ineligible or lapsing. Do we have a budget line for our campaign with that? And if so, when is that starting? Has that started already? And are we doing center radio or are we doing phone calls? How is that coming along?
So I'm going to answer a little bit, and then I may have Aaron, if I forget anything, he can definitely add. We have been working both at our clinics and our staff to be sending out Twitter messages, phone messages, information, contacting. We've asked our providers every time they come in to see their patients to remind them, working with our financial counseling teams on the county care side. They have had an aggressive outreach campaign to all their members to let them know the process of where they update their information in the website is with the state. So we can simply just tell them to make sure that they're taking these actions and to be on the lookout for the letter that will be coming from the state. And so we have done it through Twitter, through phones, through outreach, through different types of campaigns, through solicitations. We have done everything possible that we can do to make sure that our members know that this is happening, and including sending out to our partners, telling everyone across the government, saying, let people know that this is happening so that they can take the appropriate actions. So we are having campaigns to all our patients, and we're reaching out to them through text, Twitter, phone, mail, every which way that we can to let them know this is coming and that they take the actions necessary to update their information. I'm going to pause there. Aaron, did I leave anything out that you would like to share?
The only thing I would add in terms of the broader marketing to raise general awareness is we do have some dollars that we set aside in terms of our marketing campaigns to also educate on redetermination overall.
Thank you all for that. I appreciate it.
Thank you. Is there any more questions on this item? If not, we do have one more element for the board, and then we will be returning time. So I want to make sure that we can just move quickly. Any other questions, Chairman Taylor or any of the other board?
No, no further. Ileana and Angela, thank you very much for your help. Also, I'd like to acknowledge that Director Sorrell has joined.
Wonderful. And it looks like we're doing a little bit of updating while we're presenting. So for the next section of my presentation, I will also be working with Andrea Gibson, who will be giving some information on something very special that we have coming up, which is our State of the System. This is an event that we are actually doing on over a series of events. Our goal, and one of the things we heard back from the community and from our employees and our members, is they'd like to know what Cook County Health is doing, where we're going, and what we're hoping to accomplish. We went through a big section of this process as we worked together with the board and with all of our community to create our strategic plan. But what that means and how that becomes a real living document with our organization and what we have succeeded in doing in relation to those strategic pillars is what we hope to update during our State of the System campaign. So we have already started a series of events. We've held town halls with all of our employees. We've had departmental town halls with different areas of our employees for nursing, primary care, others, and we're going to continue this campaign over this first quarter of the year. And then we will also be having a public event coming up where we will be having a special presentation and update to anybody who would like to participate. And that information will be coming up forward. And so wanted to share, Andrea, to give you a little bit of an update on what we're doing as our State of Our System campaign to let everyone know what's happening here at Cook County Health, the exciting work that we're doing. And she has a special video presentation I believe she also wants to share with you. So with that, I'm happy to bring forward Andrea Gibson.
Great. And I think we're activating Plan B. Can you see my screen?
We can. I apologize, Debbie. My computer froze. I had to shut down. So Andrea's going to reflect on her end.
Okay,
wonderful.
Great. As Israel mentioned, we're doing a first annual State of the System. And this focuses on the strategic plan that passed last the Board of Directors last August, and then to the Board of Commissioners in the fall. And so that began December 1st. And so this is giving us an opportunity to showcase some accomplishments in the last strategic plan, and then also looking forward to this year, what we're going to do. And so we just have a few slides and a video to kind of whet everyone's appetite for the community meeting that's coming up in March. First, just as a reminder, we updated the mission, vision, and values as part of the strategic plan. These are the 7 pillars that you all are acquainted with in the strategic plan, and we're working to fold these pillars into, how we all are approaching our different projects. Like, so we're organizing our work under these pillars. And with that, I'll see if I can do the video.
For nearly 200 years, Cook County Health has stood as a beacon of hope and health, where everyone can get care regardless of their ability to pay, their immigration status, or their race. From our humble beginning as a small almshouse to today as a multi-campus, $4 billion health system, Cook County Health has a long and rich history of service and innovation. We have seen unprecedented changes in healthcare, from shifts in the healthcare delivery system to new health coverage options to the COVID-19 pandemic. We have always advanced with the times, and that evolution continues today. We have built new health centers in Blue Island, North Riverside, and Belmont Cregan. We made significant investments to Provident Hospital and are now welcoming back ambulances to help ensure access to emergent care on Chicago's South Side. We have been at the forefront of the COVID-19 response, caring for thousands of COVID patients and administering more than 1 million doses of the vaccine. County Care, our top-rated Medicaid health plan, has record-breaking membership, providing health coverage for more than 400,000 Cook County residents. We have explored new ways to serve our communities as a public health authority, and we tackled the monkeypox outbreak by providing vaccines, testing, and treatment. We served more than 3,000 asylum seekers, providing the ongoing healthcare services they need to start their new life in the United States. With a focus on equity, we established the Change Institute of Cook County Health, all while we continued to provide high-quality, patient-centered care to 230,000 individuals at our hospitals and health centers. With a new 3-year strategic plan in hand, we stand poised to lead Cook County Health confidently into the future. The goal, ensuring access to high-quality care for all as a provider of choice and upholding our central role in education, discovery, and innovation across the industry. Our success will be built on the 7 strategic pillars that guide our work. Over the next 3 years, we will work towards concrete goals of expanding service lines such as neurosciences, cardiovascular, and oncology, investing in essential facilities like Stroger and Provident hospitals, enhancing the county care provider network, and creating a roadmap to maximize our public health impact. We will develop and coordinate a continuum of behavioral healthcare services that extend to our outpatient health centers, to our hospitals, and to our correctional health facilities. We will continue to build our mission-driven team, and with their expertise and dedication, we will achieve key benchmarks in care quality and patient experience.
I think the most exciting thing for Cook County Health right now is our future and where we're going. We have a tremendous opportunity in front of us. Every day we stretch out to increase our network, to enhance our footprint, and we're taking bold steps to create new opportunities, new facilities to keep the promise of what Cook County Health means for our community.
Our transformation continues with the support of our dedicated team, our patients, and the communities we serve. Cook County Health is charting our path forward to equity and excellence. Together, we are achieving great things as one Cook County Health.
Great. So I hope you enjoyed that video that showcased some of the work we've done and kind of some of the pillars and work ahead of us. We'll have more detail at the community town hall that we're planning on March 15th in the evening. We hope you all will be able to make it. And any questions about this presentation?
No questions, but well done. Thank you.
Thank you.
Great. Thank you, Chairman. That concludes the report for this month.
Much appreciated. The next item, the board will now be going into closed session. Action is not anticipated to be taken in open session after the closed meeting has adjourned. Action is expected to be taken on HR committee meeting minutes after discussion in the closed session. I'm sorry, action is not. I'm sorry. I'd like to entertain a motion to go into closed session pursuant to the following exceptions to the Open Meetings Act, 5 ILCS 120-2C 1, 2, 11, 12, and 17. Do you have a motion?
So moved.
So moved.
Director.
Second.
Second, Director Arrington.
Okay, thank you. The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay? Director Bott?
Aye.
Director Curry? Is absent. Vice Chair Deere?
Here's aye.
Director Garza?
Aye.
Director Harrington?
Aye.
Director Kim? Is absent. Director Ryder?
Aye. Aye.
Director Robinson?
Aye.
Director Sorrell?
Aye.
Director Story?
Aye.
Director Webster Cross?
Aye.
And Chair Taylor?
Aye.
You have 10 yeas and 2 absent.
Thank you. The ayes have it. Motion carries. We'll now go into closed session. Thank you.